for example, in phenylketonuria, the phenylalanine blood spot monitoring, in our case, is largely run by the dietitians that are involved with the service, maintaining close contact with the patients, arranging blood spots to be sent in by post remotely, getting the results, and then contacting the patients in order to make dietary changes or medication changes. And at this stage, and certainly throughout the time of this service, the UCLH metabolic dietitians have run all aspects of that care and maintained that regular contact with the patients in order to make dietary and supplement changes depending on their blood results. There's also aspects of funding that become important to UCLH, to outreach services, which is that since these services are highly specialised, some of the medications are very high cost and really can only be prescribed by the specialised centre. So the UCLH metabolic pharmacy are very important to me in my daily work in this service, because there are a certain number of medications. I've listed some of them there, such as betaine in homocystinuria, carnitine in fatty acid oxidation disorders, and some of the ammonia scavengers in the urea cycle disorders. These are very expensive and highly specialized medications. So the centre, the specialized centre, has to do the prescriptions for these, and they're sent out from the metabolic pharmacy by courier direct to the patient. They also send out the patient's emergency packs, which might contain some of those small amounts of some of those medications that the patient actually carries to hospital if they become unwell. And then there are also certain aspects of care, for example, research trials, compassionate use medications that have special regulations for when they can be used, such as that medication triheptanoin in certain fatty acid oxidation disorders. And all of those aspects of prescribing and supplying those medications are run by the specialist centre. That relies a lot on the patient really keeping up to date on where their medication supplies are in good supply or in low supply, so they can contact the centre to arrange further couriers for delivering those. There needs to be close interaction with the local team, and that's both ourselves within the secondary care centre, but also the primary care and the CCG, because there's a number of medications that these patients are taking, such as simple vitamins, which the GP will be happy to prescribe. There are certain medications and supplements that our local GPs aren't used to prescribing. So, for example, PKU diet products or PKU supplements, that the metabolic dietitians at UCL will have a conversation with the local CCG, with the GP surgery, and always provide advice and support to allow those prescriptions to continue. And then there are certain, say, lower cost vitamins, but those that GP surgeries are not really used to providing. An example is riboflavin for some of our conditions, where the GP surgery just needs some discussion really from us and from the specialist centre to explain why it's being used. They need some support in how it should be monitored, but then in general, they're very happy to prescribe those things. So moving on to current progress, or how things have progressed. Obviously, these services will expand. So we get a series of referrals every year, 5 or 6 new referrals per year, because some of them are graduating from pediatric services. Some of them are simply patients that didn't realize that metabolic services existed in their local area, and now their GP has heard about it, they'll refer them into the service. And then others are patients who UCL have looked after centrally in London for many years, but now realise that the ongoing care could be provided by the outreach service. So we've expanded from about 30 patients up to about 65 currently in the service, and therefore the service in terms of numbers of clinics has had to expand from about 4 per year up to probably this year we'll run 6 clinics per year. Now that obviously then impacts on the specialist team having to travel these great distances to get out to the outreach clinic. And as with everything that you're learning about just now, the pandemic has had an effect, and perhaps in this case, it has had some benefits on the way the clinic is structured, because we've become so used to running clinics and other things remotely that now the UCLH clinicians and metabolic dietitians can join our outpatient clinics here in Oxford by video call using various types of video call software that can or cannot or may not include the patient within the same video call. The general model moving forward is that the patient will attend clinic with myself and the Oxford team in the clinic rooms in Oxford, while the specialist team will call in by video from their sites in London. And therefore, as a result of that, it'll be quite straightforward for me to continue to organise the local investigations and local referrals that are needed. So, summarizing, I've seen a lot of benefits, and as Dr. Dawson said, I think increasingly for you as you move from through your registrar training into your consultant posts, you will be expected to be the local point of contact for inherited metabolic disease, regardless of how well set up a local IMD clinic is. But there are lots of advantages to this. Obviously, it allows less or more easy travel for the patient, but allows, let's say, similar, if not the same, access to highly specialized services. We try and involve them in as many of the UCL activities as possible, be that research trials or other things that allows the Oxford patients to have the same level of care that a central London patient could have for these conditions. It allows, as I said, better coordination with local clinical services. And then there's a number of advantages, I would say, for the medical and other teams that are involved. For example, I've learned a lot about IMD simply through having to be the local point of contact. Many of my colleagues now, for example, for intensive care, acute general medicine, will come to me as the first point of contact with metabolic queries because they know about this service and they know that I'm the local point of contact. But also we'll have junior trainees like yourselves coming to the clinic learning about these conditions. We have senior scientists and trainee scientists, but we also have had junior or local dietitians, pharmacy staff involved in our meetings or sitting in our clinics so that they can learn more about these inherited metabolic conditions. And those opportunities weren't available to them prior to these outreach clinics setting up. It brings challenges which are ongoing, but also I think I can see challenges occurring in the future, which is that the patient numbers will expand. We know that we'll continue to get referrals from those various sources I explained earlier. And so we need to think about how perhaps expanding the number of clinicians that are involved, the number of juniors that might have to support the service. But also it starts to, although initially all of these patients were really treated as UCL patients who happen to be seen in a remote area. Now we need to think a bit more carefully about how the funding routes will move between NHS England, because this is a highly specialised service, between the central service location and between the outreach trust. And we also need to think carefully at all times about how the whole thing is governed. Are these patients Oxford patients or UCL patients, or which aspects of their care are led by those two institutions? And so hopefully it wouldn't happen, but if there was a patient incident or patient complaint, there needs to be good cooperation between the two organisations to ensure that those investigations are run thoroughly and in a coordinated way. We also can see that as these patient numbers increase, it's becoming increasingly difficult, for example, for the metabolic dietitians at UCL to be able to keep up with all the local monitoring of blood spots or all the local dietary changes. And so we're starting to investigate whether there could be some time from local services put towards these clinics from, for example, dietitians that may exist already within the endocrine service. We will need increasing support from local pharmacists, and that might need to be funded to allow them to get involved more with the pathway for these kind of expensive or more complex medications. And as the number of patients increase, we're going to need to think about increased funding for local administrative support, either acting independently or in coordination with the central highly specialised centre. But overall, it's clearly been, I think, a massive positive for the patients that have been able to come to the outreach service, and as a result of that, improving access to IMD care throughout the country. I think I'll hand back to Dr. Dawson at that point.
Still haven't got the hang of not being on mute. Thank you very much, Dr. Guha. So I hope that's given you a flavour of how you may very well be involved in IMD, going through your training and ultimately as consultants. Just want to finish by summarising our talk to say that patients with IMDs in the UK and Ireland are managed by a multidisciplinary team within regional specialist centres. But in regions where there's a wide geographical area or no adult service, care is provided through outreach clinics or clinicians from other specialties with support from a specialist centre. So you've heard there from Dr. Guha, who is a chemical pathologist, how he provides his care. But for example, the clinic I do in Taunton, that equivalent services is given by an endocrinologist. Some very rare or complex disorders, as we also touched upon, are managed within single national disorder services, again with outreach in some cases across the UK. So I hope that's been helpful, and I hope it does give you a flavour of IMD service organisation. And I think at this point, I will say thank you for listening, and please do get in touch if you have any questions.